Success of an evidence-based spine care pathway. A recent publication serves as a model for the application of scientific evidence in a real-world environment. The publication is entitled A Hospital-Based Standardized Spine Care Pathway, Report of a Multidisciplinary Evidence-Based Process. The authors are Ian Piskowski, Michael Schneider, Joel Stevens, John Ventura, and Brian Justice. Scientific evidence is rendered useless if left unapplied. Most of the time, the results of even the best randomized controlled trial are neutralized by the practical challenges of the real world. Resistance from practitioners or politicians, resource allocation, bureaucratic catch-22s, time, etc., make the application of new knowledge an uphill battle. This breakthrough study demonstrates the importance of using existing evidence to improve patient care, but most importantly provides a blueprint for others to follow. Most attempts at incorporating new care pathways are doomed to failure given the complexities of systems and the natural tendencies of human beings. So, how did the researchers overcome these barriers? The researchers demonstrated an awareness of the need for not only the knowledge, but a common goal and a plan for implementation that would warrant buy-in with all stakeholders. The first step is an agreement that change is necessary. You'll see why this is a monumental accomplishment because it does not involve just the cooperation of chiropractors, but a hospital with many separate disciplines. They started with a common goal and a process based on an awareness that there are extreme variations geographically for the care of many conditions, one being low back pain, which leads to unnecessary treatment and cost. They formed an outpatient program with Jordan Hospital called Jordan Spine Care. The disciplines are listed here. They agreed to follow a set of standardized protocols in an effort to reduce unnecessary diagnostic testing, prescription of medications, invasive spinal injections, and surgery. All of this while maintaining a high level of care with good outcomes, including high patient satisfaction, all of which needed to be measured. Next, instead of reinventing a process, they chose to use an existing, highly respected process already demonstrating success. This is an approach to low back pain developed by the National Center for Quality Assurance and their Back Pain Recognition Program. Back pain recognition status is only available to medical physicians, osteopaths, and chiropractors. However, all providers were trained in these protocols. There are some core principles upon which the BPRP are based. First, a history and examination to rule out red flags, the use of validated measures of pain, function, and mental health, minimize the use of unnecessary imaging, and only use injections and surgery when necessary. Patient education is extremely important and involves avoidance of bed rest, staying active, the recommendation for exercise, reassurance of a positive outcome based on the natural history of low back pain, and finally getting the patient to quit smoking. To qualify for recognition in the BPRP, you must demonstrate through documentation specified numbers of your patient files that you look at that process, and at the same time, we can see the specifics regarding the recommendations. There are two categories, clinical measures, or CMs, and structural standards, SS. Not all apply to non-surgeons. There are 11 CRs, or CMs, for non-surgeons, and of these, 10 must have scores generated. The 3 structural standards have only 2 that apply to non-surgical providers. Here we see the eligibility requirements for the patients that are used for the file audit used to qualify for the BPRP. This is, of course, only for the qualification process and does not apply to the application of the principles for patients after qualifying. The system is designed to manage data, meaning physicians' adherence to the protocols is monitored and feedback is given to them in an effort to increase adherence. On CM1, we see the extent of documentation for patient intake, including pain measure, functional status measure, screening for red flags, and assessment of prior treatment response and employment status. CM2 lists the must-dos for the physical exam, including a straight leg raise and full neurovascular exam, including DTRs, specific myotome testing, sensory exam, and, oftentimes overlooked, lower extremity pulses. CM3 is the mental health assessment that is required for patients with pain lasting longer than 6 weeks, including options that include the short form 36, multidimensional pain inventory or sickness impact profile, notation of anxiety, stress, or depression, and documentation of any active depression treatment. CM4 and 5 focus on reducing unnecessary initial imaging on patients without red flag indicators and repeat imaging on these same patients. CM6 deals with assistance in smoking cessation, which includes documentation of smoking status and, for smokers, advice to quit and referral for assistance if necessary. CM7 and 8 deal with encouragement of activity and avoidance of bed rest longer than 4 days. Now, beyond CM7, CM9 is very specific about the recommendation or instruction in therapeutic exercise, and more importantly, documentation of provider follow-up to ensure correct form and duration of exercise. As you can see, CM10 and 11 are related to invasive procedures not utilized by chiropractors, but clearly indicates a desire to reduce the immediate use of injections or surgery prior to using conservative approaches. CM12 is the requirement of follow-up reassessment and functional assessment 4 to 6 weeks from the initial visit. CM13 is shared decision specifically for surgeons. The first structural standard is patient education that includes the following: the natural history of back pain, treatment options, risks and benefits of treatment, and the evidence for different treatment approaches. The second structural standard is related to surgery. The third involves measuring patient satisfaction, which includes feedback about the patient's experience with care, and it indicates that there has to be a process to analyze the data and a plan for improving the patient experience based on that data. The survey must include patient access to care, quality of physician communication, patient confidence in self-care, and patient satisfaction with their care. In addition to obtaining NCQA back pain recognition status for staff physicians and chiropractors, they also trained other providers to follow the BPRP protocols, and additionally, they obtained organizational recognition status for the associated clinics, including the spine, occupational health, pain, and neurosurgery clinics. Next, the care pathway had to be designed. It needed to address the intake of patients and their triage, and secondly, determine if no red flags were found, who delivered conservative care, and based on what categorization. Tier 1 addressed the initial triage aspect, while Tier 2 addressed the different treatment categories. So let's take a look at these treatment categories and the rationale for their usage. Clearly, the first categories are based on the McKenzie approach, seeking a directional preference that's provocative for peripheralization of pain, but through positioning centralizes that pain. This is sometimes referred to as directional preference. We can see here an almost diagnostic categorization applied to the directional preference group, with the flexion bias group looking much like an alias for those with lumbar spine stenosis, and the extension bias group seems to be more indicative of those with nerve root involvement. Then we move to the spinal manipulation group. Look at the criteria. Does it seem logical or similar to criteria you might use? Well, the reason it may not is because it and the criteria for the stabilization and traction groups are based on clinical prediction rules that have been developed primarily by physical therapists and MDs. If you're unfamiliar with clinical prediction rules, please review the CPR presentation in the Chiropractic Toolbox videos. So, although these appear to be pulled out of the hat, they are actually based on at least derivation studies where criteria were teased out that seem to indicate or predict success using one of these three methods. Let's quickly look at these three methods, their criteria, and how well they perform at predicting success. For lumbar manipulation, the criteria included the following: pain does not travel below the knee, the onset of pain is 16 days or less, lumbar hypomobility was found with a springing P to A test on a prone patient, either hip has greater than 35 degrees of internal rotation, and for a questionnaire called the Fear Avoidance Belief Questionnaire, and a section of that for work, a score of less than 9. A quick comment on this CPR. Although seemingly confirmed in a validation study, there is quite a bit of criticism of these studies. For chiropractors, the largest question that remains is whether the physical therapy side posture described, which literally applies forces in the opposite direction using the ASIS, accomplishes the same outcome as the typical chiropractic side posture adjustment. We will discuss this in a future presentation. Next, let's look at the CPR for the use of mechanical traction for nerve root compression. This is an interesting combination of the McKenzie approach combined with prone mechanical traction. The rule is based on peripheralization with repeated lumbar extension and a positive crossed straight leg raise. By using these, it appears that it differentiated an 84% recovery using traction versus only a 45% recovery for those without traction. I'm sure at this point clinicians are wanting more detail, so here's a basic protocol for the application of the traction. The patient is positioned on a table that allows flexion, extension, side bending, and rotation so that the patient can be placed in a position that maximally decreases peripheralization. Static traction at 40 to 60% of body weight is applied for a maximum of 12 minutes. If the table is not initially in an extension position, the table is repositioned into extension after 3 minutes of traction. The patient remains prone for 2 minutes following traction, then performs 10 prone press-ups before getting off the table. The protocol involves 12 treatment visits over 6 weeks at max. In addition to the traction for the first 2 weeks, extension exercises, manual therapy grades 3 and 4, and education are also given. Now the CPR for the success of spinal stabilization. The derivation study has indicators of success and indicators of non-success. The indicators of success were a straight leg raise of greater than 90 degrees, aged less than 40, aberrant motion present with active standing, including a painful arc, thigh climbing, such as a Gower's sign, or reversal of the normal lumbopelvic rhythm, and a positive prone instability test. If you're unfamiliar with this test, imagine the patient lying over the edge of a high exam table so that their pelvis is supported on the table with their toes in contact with the floor. Ask the patient if there is pain with P to A pressure. If pain is provoked, the patient is asked to lift the toes off the ground with the knees extended while the examiner applies a P to A stabilizing force on the lower lumbar spine. If this relieves the pain, it's considered a positive test and there is at least an implication of instability. The predictor variable for non-success included a fear avoidance behavior questionnaire score on the physical activity section of less than 8, no aberrant movement observed on standing flexion, no hypermobility on P to A pressure testing, and a negative prone instability test response. Before we continue, we must point out that most of these CPRs are only at the beginning stages of development, meaning they have not gone through the 3 required stages of derivation, validation, and application in the real world called an impact analysis. However, they are logical choices based on the literature, and frankly, there are no obvious alternatives to their use. They do have a rationale and have all been tested through the derivation process. I know. Let's get to the results. Of the 518 consecutive patients over 6 months in this study, 116 were referred to specialty care and 7% received MRI. 432, or 83%, were treated by either chiropractors or physical therapists. 78% of patients referred to the spine center were treated by chiropractors. Here are the percentages of patients in each category. You can see the majority were flexion bias patients, followed by manipulation, then extension bias, followed by traction and spinal stabilization. This was the initial categorization. However, during their management, patients might progress to other groups for part of their care. Outcome measures used included a numerics pain scale that changed from an intake mean of 6.2 out of 10 to 1.9 out of 10. The Bournemouth questionnaire demonstrated a mean change of 23 points with a reduction of 62%. The mean cost of care for the chiropractically managed patients was only $302, and there was an average of 5.2 visits. Patient satisfaction with chiropractic care was greater than 95%. Let's look at some of the strengths of the study. This is a very pragmatic, real-world representation of the application of evidence in a complex, medically dominated environment. It includes all patient types, including Medicare, workers' compensation, auto accidents, etc. They used a standardized approach and used intake and follow-up assessment measures. Additionally, they did not stay internalized in their process. They made a monumental effort at external development that included the education of primary care physicians, spine care specialists, OCMED clinics, patients, and the overall general community through training and advertising. In fact, these efforts had a large impact on referral from outside sources to the Spine Center. Of course, all studies have limitations. Certainly, the pure scientist could find many faults with this study. But of course, the pure scientist is less concerned with real-world application and is more focused on controlled environments. As stated earlier in this presentation, great science left unapplied is useless. So, with that reminder, let's review some of the limitations. There were no control group, so we don't know how much natural history and other factors may have influenced outcomes. There was no statistical attempt at correcting or adjusting for pain severity, age, gender, etc. And there was no long-term follow-up. The clinical prediction rules used are rational, but are still not scientifically solid so that they can be entirely trusted. There was quite a bit of crossover of patients to different approaches so that the effect on data may cause misinterpretation. From a pragmatic perspective and the need to present evidence of cooperation among providers to gravitate around a goal of better, more consistent care that demonstrates cost savings, this study goes a long, long way. As politicians and payer groups look for ways of improving quality and maintaining value for the patient, this study will certainly be considered and clearly indicates the importance of chiropractic inclusion.